We're about on time now. We have about half an hour for any questions. We do have roving microphones, and I would ask anyone who wants to put a question or make a comment, observation, or just tell us about the experience on these issues in your neck of the woods, please indicate, and we'll try and pull them all in. We can get a spread of people from around. We've got one over there, one on the front row, and perhaps one in the second row here. And we'll take 3 questions at one time and then move on to the next 3. If you could please indicate the organisation you're representing and tell us that before your question, please. Okay, the first question from the gentleman over there.
My name is Alan Cleary from the Law Society's National Committee representing disabled professionals. Tim Baxter will know that the population of ancient Rome went from 1 million in 100 AD to 20,000 in 600 AD, and this was due to disease arising from a loss of skills and mistakes made by people who really didn't know what they were doing, who were taking the decisions. And I see this as a parallel to the committees and boards we've heard today, in contrast to what I regard as a better focus, the 8 core cities of England, each of which has a world-class medical school and a lot of public health expertise, largely devoted to improving the healthcare in overseas countries. And those cities are Bristol, Birmingham, Manchester, Leeds, Liverpool, Sheffield, Nottingham, and Newcastle. And I believe that the focus would be better, not placed on Whitehall and civil servants emerging to run the health services on a regional basis. Would you like to comment on that? And also draw for me the point at which a long life turns really into an extended death.
Okay, fairly comprehensive. I'll ask Tim to give some thought to that to respond. Second question in the front row here, please.
Thank you, Chair. My name is Cynthia White, and I chair the City and Hackney Older People's Reference Group, about 800 members. My question is principally for Mr. Baxter, though everybody, I think, would have a contribution to make to it. On Monday at the Westminster Forum, Minister Norman Lamb said quite boldly that because of rising costs in health and social care, we are heading fast for the withdrawal of services. Therefore, Mr. Baxter, in talking as positively as you have about the transformation in public health, could you give us a little more detail about how, in terms of the integration, which Mr. Lamb sees as essential to improving services against financial constraints, how that integration is to be addressed through the reorganisation of public health, which from my position as a patient and having worked many years in health and social care as a volunteer and through City Links, already seems to have opened up a chasm which is at times unbridgeable. I don't see the present system or structures delivering the capacity for the holistic approach to health and well-being, which you were suggesting at your conclusion was vital, and which I'm sure we all agree with.
Thank you. A question there about funding. Lady in the second row with the red coat on, and we'll make that the final question for this first round.
Hi, can I ask you the panel a question now, please, that you can answer?
Sorry, I didn't.
Can I ask you a question now that you can all answer? And it does have some relevance. Do any of you know what occupational therapy is? Can you put your hands up?
Occupational therapy, yes.
Okay, you do. And that's quite encouraging, because one of the things and it does all kind of link to all of the questions, is that I don't think a lot of the health professionals are being asked on a lot of these panels, such as the health and well-being. I know in my area, Northamptonshire, I'm also a staff governor, and I'm an allied health professional working for a mental health team. And we're actually we feel like we're being blocked from joining the health and wellbeing panels, and also the commissioning groups tend to be very nurse-led. And I think it feeds into a lot of the questions that have been raised today. today about, I know there was a comment, Katherine, that you said about not being professionally led, but I do think, I'm a healthcare professional, I'm also a consumer, I've been a service user in the past, I've been a carer, and I think we've got a lot to offer, but people, if you don't understand what other healthcare professionals are doing and what we're able to offer, then we don't know the depth that we're able to provide. For example, I work with dementia. I'm actually out there in residential homes doing a lot of the work about sort of challenging behaviour. I've worked with sensory integration, with conduct disorders. We're a very holistic approach, but a lot of people don't actually know what other allied health professionals are doing.
Okay, thank you very much for that. I will hold it there for the time being, but we have got a number of other people who want to ask their questions. Going back to the first question, I think I picked it up correctly in saying that it was a question about funding and perhaps the major cities, major universities perhaps, taking on the mantle or more of a mantle of responsibility for the health and well-being system. Tim, is that how you...
Well, I think the core cities do meet together very regularly and are very effective in terms of learning from one another and developing their particular agenda. I'd be slightly worried if this was then, if you came from, I don't know, East Anglia, to feel that the nearest core city, which I'm trying to think which that would be, but wouldn't be particularly close necessarily, was going to determine how things were run. So I think there's always a balance and a tension as to particularly where you put responsibility in the health system. With local government, the lead for public health, it's at the unitary and upper tier level. Now, you'll probably be aware that ranges from a local authority like the Isles of Scilly, which I think has 2,000 people, to Hampshire, which is well over 1 million, so does Kent. So it's a very rich but complex area. So I wouldn't wish to be too prescriptive on that one.
Just to finish off on that, I think from my perspective, the important thing is that relationships work and management works and is coordinated at the local level, and that services are driven at that local level based on the need and the joint strategic needs assessments in those local areas. I think you can have all sorts of structures and public service networks and systems imposed on any society, but what works is people. People work the system, people make the system, and it's making those connections and relationships and having that compassion at the local level which is going to make the system work effectively. And we all have personal responsibility for that, I think. The second question was an interesting one about withdrawal of reduction of services in the light of reducing public sector funding. How can you hope to improve services or the experience of the individual in that scenario?
Well, I think the first thing to say is absolutely understand it's really tough, and that the whole economy and public sector is facing very, very difficult times. Now, I can't sit here and say what's right for Hackney, and I think it very much goes back to Philip's point about people at the local level working out how best you can manage the pressures. I absolutely accept that these are times which are really, really pressured. But I think we've seen in local government over the last 3 years tremendous innovation actually in response to the pressure on finances. It's been very, very difficult, but actually local government has managed it really well.
Roger, do you want to comment here?
I was just interested in a few things. I mean, one about the long life and extended death, because obviously, I'm a dementia specialist, so that's pertinent. I think one of the public health issues is, there is this great myth that we're all living longer. I mean, we are living a bit longer, but actually childhood mortality affects life expectancy. So the developing world's looking to live longer because childhood mortality is being sorted out. Actually, apart from those that stay fit and exercise, who are probably extending their life quite well, we're just dying of different things than we were 100 years ago, and those 4 things are the big public health issues. Diabetes, obesity, heart disease, and dementia. So there are big issues through life around, nutrition, particularly, and exercise. So I think, if we don't sort out some of the public health issues, we will live longer and extend poor morbidity. As regards withdrawal of services, the impression I get at the moment is that 50% of people over 85 have dementia. You can't rely on statutory services to solve that problem. It's an own solution for everybody. And I think we've been a bit paternalistic in terms of what we might offer. And actually moving out into these structures and working with local authorities and having society and individuals own conditions rather than hope that they can be sorted out is probably a good move. I'm optimistic enough that's not withdrawal of services, it's empowering other people to own their conditions. And just about OTs, we've got 30, well, I've just retired, but we have 13 OTs employed in Swindon.
Okay, I'm conscious we have quite a few questions waiting in the wings, but the third question we had was about the Health and Wellbeing Boards and the inclusion of professions allied to health in those sorts of networks. Katherine, any observations on that one?
Well, yeah, and if I may just pick up a few earlier points as well. I mean, my mind's slightly blown by the comparison to the Roman Empire. I feel a lack in my classical education. I'm not sure I quite get that point, but I suppose underneath it is this thing about structure. If I was hearing right, there's what you were suggesting is that the localised structure may not be sufficient. We may not have the knowledge and capacity at a local level. And I think the issue is, which is where I think the Healthwatch model is quite interesting, is that we've got to take the best of local insight, regional insight and national insight. Actually, I was with Isles of Scilly Healthwatch the other day, a couple of weeks ago, and the big issue in Isles of Scilly is obviously transport to the mainland, but the other big issue that came up, it never touched the sides actually until they surveyed the population of the Isles of Scilly, which was that they had no female GP. So the big thing that they did locally was once a month they now have a woman GP who comes onto the island and serves the population of the Isles of Scilly. Now that's a very localised issue. We don't see that. You don't see that in the centre of Newcastle. I certainly don't see that in Lambeth. So there is something about making sure we don't swing the pendulum too far in the other way. So we've got to get a balance between this local insight, regional insight, and national insight. It's not an either or. It's about a balance between those. In terms of the issue around health and wellbeing boards and clinical commissioning groups, I mean, I think this is very new functioning, and I'm certain we've not got it right yet. One of the things I'd encourage you to do, just as I would all professionals, because you're absolutely right, this isn't a contest between one set of interests and another. We've got a common interest, actually, which is in improving care. So I'm absolutely with you on that. But I'd really encourage you to be talking to us nationally, but also to Healthwatch locally, to raise awareness of the kind of services that you deliver, because my view is that in the very constrained circumstances, we clearly have less. You can never do more with less, actually. What we've got to do is different with less. And this is the point that Andy was making about early intervention. The issue we've got at the moment is we spend money in the wrong places. And we've got to fix that, and actually the way of fixing that is focusing on consumers' needs in the round and getting services to deliver differently. It's as simple as that to say, but incredibly complicated to deliver. And one of the great potentials, if I can be rude to my mainstream health colleagues, one of the great potentials about Health and Wellbeing Board is that there's new sorts of money, including health money, at the table. And I know from previous lives that the real challenge in some of this early intervention was trying to get that health money to the table, because it was being spent at the end of the problem rather than at the beginning. If there's something that gives me hope in what are very challenging times, and I'm not going to take away from the challenge, it's that actually we've got a potential to start spending on the kind of programmes that Andy was describing, on the kind of programmes that other colleagues were describing, actually about proper prevention, proper intervention, rather than spending in the wrong place.
Okay. Joanna, you wanted to come in at that point?
Yeah, I was just on the OT comment. I completely agree with you. I mean, I think OTs are in quite an unusual position because you have a dual training, and so you do cross over mental and physical health, which most professions don't. And I think, you know, OTs are uniquely valuable, particularly in dementia care. I wanted to give you a little tiny bit of hope, which is that 2 big London trusts have recently appointed OTs as their trust dementia leads. So I think the profile is coming up, and I think the important sort of contribution is actually being recognised, but it's a slow start.
Okay, thank you. Any more questions there? There's a lady in the second row here who was indicated very early stages. We'll take that one next. The gentleman right at the back on the back row, please.
Public Governor for South Essex Partnership University Foundation NHS Trust. It's a question for Tim. I was very aware, because there was a very good publication about how the money was allocated to local authorities in the first instance for public health. So I am hoping that, having discussed how we reduce health inequalities up to press today, that there's going to be a better allocation of funding in year 2 of public health with local authorities, because I'm still very well aware that Kensington and Chelsea, due to historical issues, was getting nearly 3 times as much as some extremely deprived wards in Bedfordshire and in Essex.
Yes, I'm Rodney Ash. I'm an elected user governor for Sussex Partnership Foundation Trust. Last year I was in a fortunate position to arrange a conference in Eastbourne on physical health, mental health and social care. But one of the things that surprised me is, even though there is guidance to GPs that they must, not may, must see people with mental health impairments at least once a year for a full medical check, whether it be weight, whether it be height, medication, etc., it is not happening. How will the 6 members of you at the top table who address that nationally? Because I'm losing locally.
Okay, thank you. And finally, is there somebody on this side of the room here?
Good morning. Kirit Mistry from Board Member for Voice for Change England. The question is to Dr. Rake is, how will Healthwatch monitor the representation of these boards across the country in terms of its diversity? Because from our experience, that is a major challenge and a real gap. And another question really is to Tim and our colleague from Mental Health Centre. We saw that there was a programme around looking at delivering race equality in mental health quite a few years ago, and again there was a lack of continuity and investment to look at those issues. Those issues are still paramount in terms of addressing the needs of black and ethnic minority communities around mental health. And what I'm kind of wanting to ask you is, what is the plan in terms of looking at addressing these issues, and how is investment going to carry on? Because what we're seeing is investments are taking place, but are going to national bodies who've historically failed these communities, and that's what needs to be monitored as well.
Okay, thank you very much. We'll take some answers on those, or responses on those questions now. The first one was about public health budgets. Tim, do you want to pick that one up there?
Yeah, I think the first thing to say is that this is the first time that we've ever tried to measure accurately where the public health spending was. And we then had to sort of separate it out and transfer it over. Now, you'll be very well aware that the investment in public health varied hugely across the country for all sorts of good and not so good reasons. So in allocations, you've always got a problem. You come up with your allocations methodology. We were advised by the Advisory Committee on Resource Allocation. And you come up with target allocations, but generally you'll find in any particular area they're either above or below, and there's a question of how far it's sensible, how quickly it's sensible to move towards the target allocation. And basically, I think the decision ministers made was, well, they wanted to try and make sure there was stability in the system so that we didn't suddenly reduce the amount in particular areas or vastly increase them in others. So they went for making sure that no area lost out, and those areas which were most below their target allocation got a bigger increase. Now the result is that, and I was in Merton earlier this week, and it was pointed out very forcibly to me that Merton had about a third of what Wandsworth had. And it's true. But there is always this issue of how quickly you can move to a more rational allocation, and that's the aim is over time that we do move to a more rational allocation. And also what the advisory committee are going to do is to try and improve the data so that they're really getting an allocation formula which looks at the drivers of poor health. There's a danger with the current formula is that an area which really did wonderfully well in improving the health of its population might find its allocation cut. But actually it needs continuing level of investment to keep that performance up. So for example, on smoking cessation, you need to continue working away at smoking cessation even if your smoking rates are fairly low, because otherwise they're likely to creep up again. So appreciate it's very much work in progress, the allocation at the moment.
I think just to add to that briefly, if I realise that the public health budgets have been transferred to local government, they are ring-fenced, allegedly, and the Health and Wellbeing Board has fairly direct control over the use of that amount of money, but it has influence on an awful lot more than that. And that's the key, I think, to the workings of Health and Wellbeing Boards. They and the Directors of Public Health and other local government staff and partners in Health and Wellbeing Boards need to be able to influence the bigger spend in the health sector rather than just focus on the spend of their own public health budgets. The second question was about mental health services. Roger and Andy, do you want to pick that one up and comment on that?
Yeah, it was a great question. I guess for all of us, as soon as we're told we must do something, then there's always a bit of pushback, and that's just human nature. I think there's no great answer to that other than you just keep pushing and telling people to do it. But I think core to some of that debate, and also what we heard just now, is it's the specialist versus generalist debate. You know, there's an awful lot of stuff that's done in the health service, particularly, that is still done by specialists that could be done elsewhere. You know, and IAP's a great example of, you know, they're not the high-end people that are doing IAP, they're trained people who deliver people's needs. And I think, you know, there's an awful lot in the health service that could be done differently by different people with supervision from specialists rather than having to go through specialists. And I think, you know, if you explain to GPs that actually they're seeing a lot of these people 3 or 4 times a year anyway, if once they stuck a stethoscope on the chest and did a few things and measured their BMI, we would be happy about that, then that's a more reasonable thing than saying you must do this, that and the other. But I think specialism historically has always compartmentalised things. And, you know, we're not at the state of the US yet where you go and see someone for one bit of the body and someone else for another bit. But, you know, we're getting that way. And some of it ought to be empowering the generalists to do more without making them feel they're doing a lot more work for it. And that's a difficult balance. But, you know, I think a lot of the money, as you rightly said, is tied up in some very expensive people doing some stuff that other people could do. And that's, you know, is a public health agenda.
Andy?
I think, we've got this system now for general practice, kind of points mean prizes system, haven't we, with the quality and outcomes framework where GPs get paid to do particular things, and I think there's a question about whether that's the most effective way to incentivise the right things, if you like, and we need to look at how we can encourage GPs or require maybe GPs to support the physical health of people with a mental health problem and the mental health of people with a physical health problem. And we've got a long, long way to go for that. I think also for people who are using mental health services, we need to make sure that within that mental health support, we are looking after people's physical health. Psychiatrists are doctors, and I know the Royal College of Psychiatrists is trying to remind its members that actually they do have training in physical health. They can support people to lead healthy lifestyles, to do health checks. Do it in the places people are. Don't expect people to go to one different service for one thing, as Roger was describing. On race inequality, it is shameful, I think, that within mental health care, we still have such dramatic differences in experiences of service from different ethnic groups. There was a plan called Delivering Race Equality, which came to an end, and I think to some degree the poor results from that programme have cast a blight on any kind of policy response to it, and at the moment I think it's fair to say there isn't a plan to address race equality in mental health, and we have to get back to it. The Centre produced a report 10 years ago now called Breaking the Circles of Fear, which described some of the reasons why African and Caribbean communities in particular have such poorer experiences of mental health care as other communities. I think we need to go back to that, and I think there's a huge public health role to look at what's happening in childhood that leads young people from black communities to end up in these very negative, coercive relationships with mental health care in the first place. So we take a whole life approach to this, rather than just trying to focus on what's wrong in mental health services.
Thanks, Andy. Katherine, do you want to pick up there was a question about Health Watch and the monitoring of Health Watch boards locally?
Yeah, I mean, I think it's a critically important point, and part of the benefit that should come out of localising this is actually to have a more representative cross-section of your local community, not only on the board but within Health Watch itself, and more generally within your decision makers at your local council, within your decision makers within your local health and social care system. My goodness, there is a long way to go on all of that, and I think it's incumbent on all of us to take a responsibility to make sure that we get that diversity happening and get that engagement, community engagement happening, because we're a long way from where it needs to be.
Yeah. Well, I think I've got time for one more question.
Thank you very much, Chair. Before I ask my question, I would just like to say thank you to the panel members for giving such a good presentation. My name's Ambrose Koryang, and I work for a social enterprise in Birmingham called Health Exchange. And my question was really in relation to your opening speech earlier in regards to how what goes around comes around. We deliver a program that tackles the health inequalities within the local communities, which is part of a Department of Health program. But my issue is there seems to be a rhetoric in terms of services that come up to tackle certain issues, and by the end of that program, the conclusion from those services might elude that in terms of the DRE program, that nothing has happened. A few years after that, another program would be established by the Department of Health to tackle yet again that same issue. I want to know, is there an agenda within the current redesign of the health service to kind of put a stop to that? Because we all know what the issues are generally within our society in terms of the obesity issues, in terms of mental health, but we've had such a number of different programs designed to tackle the same issue. So is there a plan in place to make sure at least that's brought to an end?
Anyone want to jump out and pick that one up immediately?
I think the point I took from that was that certainly the Department of Health and other central government departments are far too ready to launch new initiatives and programmes without really focusing on what works. And I think there's a certain amount of guilty as charged there. Point I would pick out in terms of Public Health England is its role as, along with people like NICE, to be very clear about the evidence base and what does work. And I think there's a major challenge in public health generally about moving from lots of good initiatives which run for a year or two but then fade away to really kind of, as some of my colleagues used to use the phrase, industrialising public health, and things which we know work, make sure they're spread properly, locally adjusted as necessary, but actually really focus on what we know works, because if we do that, then there's an enormous amount of gain we can make without actually, before we even get into the really innovative stuff. Anyway.
my experience of sitting on these panels is you always have to watch the people that are very complimentary at the beginning because they always ask the killer question, and you've actually asked the absolute killer question, which is how do we close this gap between rhetoric and practice? Because I think you're spot on. There's an awful lot of talk about changing practice and all the rest of it. And if there was as much action in terms of changing practice as there was talk, we'd be in a different place. I mean, there is a sort of industrial scale within health and social care, and that's, I think, also where I think having eyes and ears on the ground is so critical, because there is a huge force, which is the force of people, to make sure that we keep those practitioners on their toes, which is the point that was made earlier, again, about, the practice in Eastbourne, so a commitment, to say we've got to have a visit annually and it not happening, and actually holding the mirror back up to those services, provider by provider, I think is the way that it needs to happen. And it's not because the professionals are unwilling, it's because they have an awful lot on, and actually they forget sometimes what they need to be doing. They get pulled into financial targets rather than people-driven targets. So I do think that your question is spot on, and I do think that actually part of this is empowering individuals to begin to challenge that practice, and empowering communities to do the same, because that's where the real force is going to come in this rather vast and monolithic system.
Okay, thanks very much. I think one thing I could perhaps add to that is that one thing I would hate to see in the near future is any more system change for the foreseeable future. I'm mindful that we have a general election in about 18 months' time, and there's a bit of uncertainty around the position of some of the parties on the healthcare system generally, but I would hate for there to be any more system change for the next 10 years. Let's get some stability into the system and let the health and well-being boards have a go at making a fist at the role of coordinating healthcare issues in the locality. For those people who've had their arms vigorously waving in there and we haven't been able to devote the time to respond to those questions, there is in fact a facility on the Govtoday online portal. So if you're going away from today's conference feeling that there's still something you want to raise with any of the people on the platform or any people here today, then please go and log your comments or queries on the online portal. And I think you'll find details in the delegates pack of how to do that. Thanks very much to the panel members this morning. I'd ask you to show your appreciation for the panel presentations this morning.